One of the late-breaking clinical trials is the Elevate-Timi 56 trial. There's a fascinating look at uses of very high daily doses of clopidogrel to try and overcome clopidogrel resistance based on genetics. Dr. Jess Mega of the Timi group is here and presented the study. Can you tell us how you got into this pharmacogenetics study?
It's a great question, Chris. Well, you know, we give patients 75 milligrams of clopidogrel and we use one standard dose. But it's become fairly clear that patients have variable response to clopidogrel. And one of these underlying factors is a patient's genetic makeup. And so about 1 in 3 patients have certain genotypes that make them less responsive to the standard dose of clopidogrel. And we thought it would be very interesting to see if we could overcome this genetic resistance by giving higher doses of clopidogrel.
So you used up to 300 milligrams a day, but only in those who had the 2C19 allele?
That's right. So patients who were 2C19 star 2 carriers got up to 300 milligrams a day, and that's 4 times the standard dose. And what we ended up seeing is that you needed to triple the dose. So you needed to give patients at least 225 milligrams of clopidogrel, and these are the patients with the genetic variant. We needed to give them 225 milligrams to get the same response that you get with 75 milligrams in patients without the genetic variant.
Well, that's amazing. And how about you studied also the homozygotes that have been part of the FDA label. What did you find there?
Great question. So the homozygotes make up a much smaller portion of the population, so about 2% or so. And what we found there, that even with 300 milligrams, we were unable to achieve platelet reactivity that was similar to 75 milligrams in non-carriers. So it seems like clopidogrel may be hard to use that medication even at high doses to achieve optimal platelet inhibition.
Well, this is obviously fascinating to try and incorporate genetic testing and then using, what will soon be a generically available drug, presumably at lower cost. Where would you see this fitting in terms of implementing a strategy like this?
Well, you're right. There are newer agents. So we know that there are newer dinopyridines and newer P2Y12 inhibitors that are going to be available. But clopidogrel really does appear to be here to stay. And as you mentioned, there will be a change, and it will be going generic in 2012 in the U.S. And with that in mind, we really wanted to understand how to use clopidogrel in these patients with particular genetic variants. And so obviously, large-scale studies are going to be needed to look at clinical outcomes, but I really think this helps us get a better sense of the dosing in these patients.
Well, it's certainly true, and I wouldn't want to be one of the third of patients and be getting clopidogrel, so to have an understanding of the problem and now potential solutions is very exciting. So congratulations. For Cardiosaurus Video News, I'm Chris Cannon.